Greetings. I would like to thank the societies for this opportunity. And these are my disclosures. And I would like to talk about closure devices, the role of a technician, and the role of endoscopist in managing colorectal perforations after polypectomy. A number of devices are currently available through the scope clips, over the scope clips, through the scope and over the scope suturing devices. Through the scope clips can take care of all post-polypectomy perforations because they can be deployed immediately without removing the scope, and most perforations tend to be small, and these can be closed with through the scope clips. A number of clips are available, and I urge you to visit the exhibit hall to learn about them firsthand from the exhibitors. I must add here a trained technician ready to anticipate the problem and be ready to assist you is critical for successful endoscopy procedures. When it comes to training, unlike in the past, currently there are formal training opportunities to become an endoscopy technician, trained either at ASGE or the community college, and even at my own institution. One thing that is critical when you're performing polypectomy is to make sure that the endoscopy technician checks the inventory and make sure that clips are available in the room. This is very important. You don't want to have your technician running around to find a clip. There are three simple steps for operation. One, open the clip. When it comes to closing the clip, it should be done slowly. And the third step, deployment should be done only on command. And this is an important step that every technician should learn before a clip is deployed, so that it gives an opportunity for the endoscopist to change or readjust the closure if necessary. When it comes to the art of clipping, the most important principle is deep clip application. This is critical for success. What do I mean by deep clip application compared to superficial clip application? As you can see here, there is a gap between the two blades of the clip after closure. This is superficial clip application, and these clips are going to fall off very quickly. How do you avoid this problem? In order to appreciate this, one should understand that every clip that is available in the market retracts on closure, and you have to compensate for that retraction by either gently pushing the clip or the scope before you deploy the clip. And as you can see here, this is deep clip application. And let me go back to show you that superficial clip application, there's gap in between the two blades, and with deep application, you don't see any gap. This is a very important point to keep in mind for secure clip closure. So now that we learned what the technician should do and what the endoscopist should do, and it is time now for us to reassure the patient that if a perforation were to happen, these perforations can be managed by the endoscopist and does not need surgery. So when it comes to how did we come to this? A lot of work has been done that has shown that clip closure heals perforations, create a leak-proof sealing, and we have also figured out what type of closure is preferred. Longitudinal closure works better than transverse closure, and clip closure is better than surgery. And now we have a lot of literature to support that clip closure works. And we should be able to tell our patients that if a perforation were to happen during polypectomy, we should be able to take care of that. It's important for us to practice a safe cut and avoid perforation. When it comes to that, the principles start with a clean colon. A dirty colon, if a perforation were to happen, will require surgery. The endoscopist should have full control of the scope and able to have a good tip control so that he knows what he's doing. And finally, routine use of CO2 instead of air, if a perforation were to happen, would avoid the risk of tension pneumoperitoneum. Before you undertake a polypectomy, get into the habit of cleaning the colon and clearing the fluid, both proximal and distal to that large polyp resection, so that if perforation were to happen, risk of fluid escape through the perforation could be avoided. Before you cut, ask yourself, is the lesion dependent by flushing some water? And if it is dependent, don't cut, because these types of resections, if they end up with a perforation, fluid escapes out into the peritoneal cavity. Instead, change the position of the patient, make the lesion non-dependent before you cut. When it comes to the snare selection, my preference is a smaller snare in the right side of the colon, especially if I'm doing EMR. This would avoid the risk of entrapment of deeper tissue and have a much better controlled cut. It's also important to appreciate the principles of preserving the submucosa whenever you're cutting, because submucosa is the strongest layer of the colon. As long as you preserve the submucosa after cutting the mucosal compartment, you are unlikely to have perforation on your hands. Coming to your resection technique, make sure you have your electrosurgery in front of you so that you know the current that you're delivering. With the older versions of the ERB generator, it gives that audible signal. And if it takes more than 3 beeps, you know that you have applied too much current and you may end up with a delayed perforation from the current injury that is not obvious immediately. Coming to the principles of snare resection, keep the snare parallel to the wall. This would avoid the muscle entrapment. And another principle is, once you close the snare, if you see too much of movement underneath the snare, and if you are in doubt, release the snare, distend the colon, and let the muscle fall back away from the snare before you cut. And once you cut, get into the habit of examining the resection base after every cut to figure out how deep was your cut. So let us talk about how do you assess the depth of resection and how do you use that information to manage a particular patient. Here, as you can see, the depth of resection is limited to superficial submucosa. Perforation risk is 0. Here you see still a faint amount of deep submucosa. Again, the perforation risk is 0. When you have a doubt and you see white area, you don't know whether it is muscle or not. In that case, you can spray a little bit of indigo carmine to see whether it takes up the dye. If it doesn't take up the dye, you may want to consider clip closure of the defect to prevent delayed perforation. Regarding discharge or hospitalizing, you have to take into consideration various parameters like age of the patient, comorbidity, and if the patient is symptomatic or not. If there were to be a full thickness resection with perforation, but there was no contamination of the peritoneal cavity, you should diagnose perforation, clip close the defect, start antibiotics, broad spectrum antibiotics, and make sure you observe the patient and the recovery area for a longer period of time. And if they are healthy with no comorbidities, you could actually discharge the patient. And if they're asymptomatic. On the other hand, if you have a doubt, make sure you admit the patient. In contrast, if there were to be contamination of the peritoneal cavity, in addition to attempting closure, broad spectrum antibiotics, these patients should be routinely hospitalized. A CT scan of the abdomen and pelvis with contrast should be done as soon as possible, along with a surgical consultation. Say, for example, you have a defect and you thought you had a perforation, you close the defect. It is important to document that you have achieved secure deep closure, edge-to-edge closure, by taking photographs from both sides of the defect. That is very important so that the surgeon can feel comfortable working with you. I must add here that even though you close the defect, keep in mind that clips can get detached, and clips could cause issues with laparoscopic closure. Clips may give you the false sense that you have closed, but slow leak can lead to peritonitis, and instead of simple closure, the surgeon, if he goes in, may end up doing a diversion procedure. These are the pitfalls of clip closure. And when it comes to surgery after closure, early surgery, if there was dirty colon, if there was spillage, and if there was clinical deterioration, while examining the patient carefully in the recovery area and during early hospitalization. Let me summarize the management of post-polypectomy defects and perforation. If there was a deep injury to the muscle or perforation with or without pneumoperitoneum, these patients can be managed with endoscopic closure. Patients who have spillage and peritonitis, they need to have surgery as soon as possible. Regarding how to close the technical details, I have assembled here a lot of videos for you to review at your convenience and hope these will be helpful. Thank you.